I'm sure you've probably heard of post-operative incentive spirometry use, but what about using incentive spirometers before surgery? That is the topic of today's episode. Welcome to the Researched RN podcast. I'm your host, Stephen Kuzmenko. In this podcast, I discuss new and interesting peer-reviewed research articles from various nursing researchers and other professional publications. In the 13th episode, I'll talk about an article published in the August 2021 edition of the Journal of Cardiothoracic Surgery titled Preoperative Incentive Spirometry for Preventing Postoperative Pulmonary Complications in Patients Undergoing Coronary Artery Bypass Graft Surgery, a prospective randomized control trial. It's authored by Sweety and colleagues. To start off with a little bit of the background, we know that coronary artery disease is the leading cause of death and disability worldwide in the United States and abroad. And so one of the mainstay treatments for this disease, coronary artery disease, is the CABG surgery, coronary artery bypass graft surgery. This involves taking a vein or even an artery potentially in another part of the body, surgically implanting it in the heart before the blockage so that that vessel can then deliver blood past the blockage to the rest of the heart muscle that is blocked because of the coronary disease. And there you have bypassed the blockage. That is a great treatment and it does save lives. Of course, it comes with complications of surgery. Infection, pleural effusions, pulmonary edema can happen, respiratory insufficiency. Those are just really related to the ventilator associated problems that can occur. Of course, you can have delirium. I've talked about that in other episodes. You can have pressure injuries. There's a lot of other things that can happen. But with regard to the more pulmonary focused complications, infection can occur, pulmonary edema, and specifically atelectasis can occur. Atelectasis has a lot of contributing factors. It could be attributed to dysfunction of the diaphragm. There's a shift in the chest wall regarding the surgery. There's pain that occurs, so people are less likely to want to do the exercises, get up, to cough. And then pleural effusions can contribute to atelectasis. And atelectasis is prevalent in a lot of patients that not just undergo CABG, but a lot of other surgeries. But it's also preventable. There are many interventions that can prevent what they're referring to in this study as postoperative pulmonary complications, PPCs. Of these interventions, of course, mobility, proper pain management, and incentive spirometry. And we usually think of these interventions being implemented post-operatively, really focused there, right? But of course, there are things that we are doing more, and it depends on where you work. We're doing more things before the surgery because it's associated with better outcomes. And so another study that these researchers use to kind of justify the need for something before the surgery, we should do something before. There was pre and post-op video-based education on the interventions to prevent post-operative pulmonary complications, and it found to reduce the rates of atelectasis as seen via chest x-ray. And so they know that, and we know that incentive spirometry is helpful to promote these guided deep breathing exercises. So they felt like, well, why don't we implement this preoperatively? Incentive spirometry, briefly, if you don't know, it's a small device. It can be made of plastic, but it's really light and small handheld device that provides real-time feedback and guides inhalation and holding breathing patterns. So it really kind of forces patients who use it to do long and slow, deep breaths, which can promote lung expansion and ventilation, making it harder for atelectasis to take hold. Now, that sounds great. Unfortunately, the literature on IS, incentive spirometry, is somewhat conflicting on whether or not IS reduces postoperative pulmonary complications. There are some studies that show no benefit and others that show a clear reduction in these complications, and even some studies that show reversal of atelectasis, which in those studies led to shorter hospital length of stay, which is great. IS in general is the responsibility of either nursing or respiratory therapy staff. And while incentive spirometry really does need to be implemented post-op, which I'm sure that's ubiquitous across all healthcare settings, not just in the United States, but in Canada and the United Kingdom and Australia, it can be placed before the surgery. Now, even with this thought of let's do it before and after, in general, there's no definitive incentive spirometry protocol. Studies in the literature have shown varying degrees of what that looks like. What does the optimal IS protocol look like? Whereas one study that they cited required the participants to engage in the IS exercises 3 to 5 times every 1 to 2 hours. And so in my practice, what I've seen clinically, I see 6 times per hour for all waking hours. And so that is another problem that exists in the literature with regard to incentive spirometry. So more research is needed on incentive spirometry in general, and more research on whether preoperative use is beneficial is also needed. And so that is exactly what these researchers aim to do. The study aimed to evaluate the effect of preoperative incentive spirometry in preventing postoperative pulmonary complications, improving postoperative oxygenation, and decreasing the length of stay in the hospitals in patients following CABG surgery. And so now we get into the study design. How did they make this happen? How did they measure whether or not this was effective? It was a prospective, randomized controlled trial. This happened in the National University Hospital in Palestine. The hospital there was approximately 200 beds. And in their cardiac area, there's 5 coronary care unit beds or critical care beds, and then 16 intermediate coronary care unit beds. So that's kind of like the step down. The participants, there was 40 patients in the control group, 40 in the intervention group. To be included in the study, the participants had to be 18 or older, undergoing a scheduled CABG surgery. They had to be well motivated and compliant. Exclusion criteria was a long list. They were patients that were expected to not be compliant or unable to comply with instruction due to cognitive or neurological deficits. Patients were not included if they had acute or chronic respiratory disorders. This could be asthma, COPD, active pneumonia, tuberculosis. Patients that were confused or delirious were not included as part of the study. If they had any other surgery in addition to the CABG, or if they had an emergency CABG, they were not included. And if they had experienced prolonged intubation post-op, more than 24 hours, or if they were re-intubated, they were not included. Then lastly, any patients with chest or thoracic cavity physical deformities were not included. So quite a long list of exclusion criteria. But nonetheless, the intervention was incentive spirometry for 2 days preoperatively, and that was 10 breaths, 6 times per day. This intervention was taught by a nurse, which I think is really great because some of the researchers, or rather not all the researchers, are nurses, but the intervention here was delivered by a nurse, and that nurse was not involved in the post-operative care. That was the intervention group. The control group had no preoperative incentive spirometry. They only had the post-operative standard of care. Even the surgeons and the radiologists, the surgeons operating and the radiologists reading the chest x-rays, were unaware of which participants were in the control or intervention groups. And so that's the study design. The outcomes. The primary outcomes were looking at whether respiratory complications within 48 to 72 hours occurred. These post-op complications included atelectasis, pneumonia, pleural effusions. pneumothorax, and these were all measured by X-ray or clinical signs and symptoms. There were secondary outcomes, the first one being hospital length of stay, the second one durations of mechanical ventilation in hours, the third oxygenation status, and they measured that with the PaO2 and the SaO2. This was obtained via blood gases. And the fourth secondary outcome was the degree of pain control using the numerical scale. So how well was pain controlled, which I think was interesting, thinking that maybe the use of in-center spirometry before surgery could benefit pain after surgery. I think that was pretty interesting there. I also want to mention the assessments and the way that the data was measured and evaluated was approved by 3 ICU nurses. So kudos to those nurses that participated in this study. And so here are the findings. Here are the results of the study. The main outcome, the reduction in postoperative pulmonary complications. There was a significant reduction in postop atelectasis across the 3 days. The average rate of atelectasis in the control group was 22.5%. So almost, 1 in 4. In the incentive spirometry group, the average rate of atelectasis was 9%. So 9% of people in the intervention group got atelectasis. 22.5% in the control group got atelectasis. That's more than twice the occurrence. On day 3, in the incentive spirometry group, there were 0 cases of atelectasis, whereas in the control group, there were 4 cases of atelectasis. But with regard to the other respiratory complications, there were no differences that the researchers reported, and really the actual complications themselves were not reported. They just said that there were no significant differences between the groups with other respiratory complications. And so now we move on to the secondary outcomes. So mechanical ventilation time. In this study, did the use of preoperative incentive spirometry mean less time on the vent after surgery? And the results for this study say yes. The average time that the incentive spirometry group was on the vent was 4 hours. In the control group, it was 6 hours. And none of the participants in this study needed to be reintubated. And so that I think is really cool. Less time on the vent by an average of 2 hours. The hospital length of stay. The incentive spirometry group on average spent 1 less day in the ICU and about half of a day less in the intermediate care unit. And overall, the overall hospital length of stay was reduced by 1 day on average. So on average, they're in the hospital for 1 day less, which can potentially be thousands of dollars, and you get to get home sooner. In regard to the oxygenation, the incentive spirometry group post-operatively did show slightly higher PaO2s and SaO2, so their oxygenation was better. And there were noticeable differences. If you look at the study, if you find this article, there's a chart that shows you the SaO2 and PaO2 for both of the groups, and it was pretty noticeably better at 6 hours post-op, which they also mention in the study as being significant. And that makes sense because that was about the time that the incentive spirometry group was already extubated on average, and the other group was about to be extubated. So I think that there might be some benefit there. And then the last secondary outcome was pain control. So the IS group reported less pain while being on the same pain regimen. And if you can find this study, and there's a chart that shows the pain scales by the 78-hour mark, 78 to 90 hours post-op, so a little over 3 days, they actually were reporting a pain score of 0. So that I think is pretty amazing. They didn't need as much pain meds. They still had pain, of course, but they reported less pain. Now, what they don't report is, the actual administrations. Did they administer more or less? But at least we can see that the patients at least subjectively said that they were in less pain. And so those were the outcomes. They had a reduction in atelectasis. They were oxygenating better post-operatively. They were off the ventilator sooner, and they were out of the hospital just a little bit sooner. And really, in hospital terms, 1 day is kind of a big deal. And this is all because of the use of these little plastic devices called incentive spirometers. They're not that high tech. At least the ones that I've seen are pretty simple. So it's pretty simple, low cost intervention that can potentially have a lot of financial benefit, which I thought was interesting. They didn't really speak on that as a benefit, the finances of the reduction in hospital length of stay. This article does a really good job of highlighting the results of other studies that they contradict their findings. And then, of course, they cite the studies that kind of confirm their findings. And so that kind of leads us into our discussion. So, in general, we see that the use of uh, incentive spirometry preoperatively can improve respiratory outcomes and can reduce recovery time. I mentioned the fact that there are studies that have found conflicting outcomes with regard to this study, but nonetheless, it's something that should be further investigated. Now, one of the things that I think might have happened, particularly with the pain control, is the fact that the nurses that were giving them the education to use the incentive spirometer preoperatively, they really just kind of mentioned the education was given by a nurse and this was the protocol. But I'm sure that they were also asking them general questions about the surgery and how they were going to feel and was it going to hurt and how are they going to treat that pain. So, that could have happened, and maybe that is what we're seeing on the tail end of the results, and specifically with regard to the pain control. Now, where that does shine, the use of preoperative intervention, is the fact that the education does not need to be as dense post-op because they've already gotten it. So they were educated on how to use the incentive spirometer. They were educated on why and what it does for them. So that doesn't need to be quite as in detail post-op because they've already gotten the education. So that can help with compliance post-op. You can say, remember what they told you before your surgery. This is really important. Whereas the patients that did not get any intervention preoperatively, you had to teach them how to use it, why it's important, and you have to keep bugging them all while they're waking up from surgery and probably in pain and having trouble getting up out of the bed and just doing all the things, eating, going to the bathroom, coughing. And so it's hard to educate people in that situation. So the fact that that group had already gotten the education, I think, played the biggest or a huge role in the compliance post-op and therefore the results, these positive results post-op. But it's important that we do note the limitations of this study. This study occurred in Palestine. It was a small sample size, 40 control, 40 intervention. It was a single center design, and there were no patients that were in this study that had underlying lung disease. And so, of course, they also suggest this, but future studies should have larger sample size, multi-center. This study was randomized, so they got to keep that, as that's going to be better off for as far as like the reliability of the results. But the future studies should probably include patients with other lung diseases just to kind of see how they fare with this specific intervention. And this was only 2 days preoperatively. Does it only need to be 1 day pre-op use of incentive spirometry? Does it need to be 3 days, 7 days pre-op use of incentive spirometry? And so those are other things that they could be investigated in the future. I think the other thing to think about too is whether or not this intervention can help for patients that are undergoing other surgeries. This was just patients undergoing CABG, but any other surgeries that exist, which there's probably a ton: orthopedic, general surgery, neurosurgery, other types of thoracic surgery, vascular surgery. I mean, there's so many other surgeries that take place. And so that could be another study in the future outside of patients undergoing cardiac surgery. Does incident spirometry before the surgery help after? And so now we're finishing up with this episode. The big takeaway message, I think, from this small study is that preoperative incident spirometry use can help when it's combined, of course, with deep breathing, coughing, and ambulation. But the fact that I think it's given before the surgery can help with education and compliance post-operatively. I think this study also highlights the nurse's key role in teaching and supporting IS adherence. And so, if you're at the bedside, even if you're not, in the immediate post-operative period, you're in that intermediate or step down area, you can still encourage, and you should still encourage, the use of in-center spirometry based on the protocols that you know is prescribed to the patients that you care of. And I think that you should take charge in incorporating education, of course, in that area as well, and maybe even consider exploring in your work area if this can be implemented preoperatively. That of course takes buy-in. You have to create a whole program, get support, who's going to deliver it. It's a lot of work, but it's something to think about. And what I am curious about is if anyone does this already. Uh, Before reading this study, I didn't think about using sensorometry preoperatively. So maybe some of you that listen to this already do that in your practice. I do have listeners that listen to this show from the UK, from Canada, from Australia. I have listeners in Poland. If you are in another country outside the United States, I'd love to hear whether or not you do this already. You already are using preoperative incentive spirometry, and maybe I'm just late to the party. So let me know, email me. But that is a wrap on the 13th episode of the Researched RN podcast, your virtual journal club on the go. I am your host, Steven Kuzmenko. I'll have new episodes out at least monthly. Email me at researchedrnpodcast@gmail.com with any articles or topics you'd like for me to discuss. If you enjoyed today's episode, please share with a friend, and it would be a huge help if you gave me a positive rating so others can find me. Thanks for listening, and be sure to tune in to the next episode.